online teaching program for postgraduates in pathology. Today, the topic will be approach to salivary gland neoplasm, and our chairperson is Dr. Gauri Pantavaidya. She is professor in Department of Surgical Oncology, Tata Memorial Hospital, Mumbai. Presenter is Dr. Anita Borges, ma'am, Lab Director and Pathology Center for Oncopathology, Mumbai. I request all students to introduce themselves, starting from Bharti, then Jupita. So, students, please introduce yourself in brief.
I'm Dr. Bharti from
Bharti.
Pondicherry Institute of Medical Science, Pondicherry. I'm second year postgraduate.
Hello
Jupiter.
everyone, I am Dr. Jupiter Rekha, second year resident from Guwahati Medical College, Guwahati.
Prachi.
Hello, I'm Prachi and I'm from PDU Medical College, Rajkot.
Good evening, this is Dr. Dhanushree from KIMS Bhubaneswar, second year pathology PG.
Hello everyone, this is Dr. Meena, second year postgraduate from JJMMC, Davangere.
Chetan.
Person is not there, right?
Good evening, everyone. I'm Dr. Chetan Agarwal, second year PG from Muzaffarnagar Medical College.
Moderators for today are myself, Dr. Sandeep Ojha. I am consultant histopathologist at Balco Medical Center, Raipur, and Dr. Manali Ranade. She is fellow molecular pathology at Tata Memorial Hospital, Mumbai. Webinar hoster Anita Borges, ma'am, and Sumit Gujral, sir. A few reminders. In case of connection interruption, low or no sound, video freezing or video lag, kindly leave the meeting and rejoin with the same link. If the problem persists, please check the internet connection. Answer the poll question, if any, by typing the chat box, or ask your question in the chat box only. Please do not send the request for annotation to the presenters. There are few disclaimers. Few more. Just to remind you for the next upcoming talks, next slide seminar is on complete blood count by Dr. Kunal Sehgal, consultant hematopathologist in Dr. Sehgal Path Lab, Mumbai. And next talk is on 12 December, approach to anemia by Dr. Mukul Agrawal, Department of Pathology, Hematology, AIMS, Delhi. So let's start with the today's session. I request Borges ma'am to start with the session.
Sure. You need to stop sharing your screen. Yeah, good.
Yes, ma'am.
All right, good evening, everybody.
Good evening, ma'am.
Good evening.
Good evening, ma'am.
Can you see my screen?
Yes, ma'am.
All right.
Ma'am.
Okay. Now, you know, today is just an introductory talk to the in which I'm going to tell you the approach to how to make a salivary gland tumor diagnosis. Okay, and there you see something on the screen over here, and you see 3 panels on the top of the screen, and you see 3 panels or 3 pictures at the bottom of the screen. All right, and you see this. You see the Cinderella story written on top, and then there is the Cinderella cell that is written below. I have 5 students over here, and 6 students rather, and I just like to ask any one of these 6 students or all of you, have you ever heard of Cinderella? Will somebody say yes or no? Who has heard? Chetan, you've heard?
Yes, ma'am.
All right. So you want to tell everybody who or what was Cinderella?
Yeah, ma'am. She was orphan and she had a stepmom.
Yes.
And she was not treated nicely by stepsisters and stepmom.
Yes.
She finally found a prince.
Sorry, what happened? The family found a prince?
No, she found a prince,
Yeah.
or rather a prince found her. And
Correct.
she
Very
attended the party. She was given good dress by a fairy godmother.
Ah.
And
Okay, so you see the fairy godmother. Here is Cinderella. Just
Yeah.
as Chetan said, nobody used to notice her. She was known as Cinderella because cinder is a word that means ash. Her real name was Ella, but because in the cold countries they have chimneys and they have to scrape out the chimneys, and the people who do the scraping are usually the maids and those people who are employed to do that. Cinderella was always covered in ash, and that's why she was called Cinderella, somebody who's covered in ash. Her real name was Ella. Okay. And that there was a big, you say use the word party, but it was a dance party, and a dance party is called a ball. Okay, to which everybody was invited, but Cinderella was not, because nobody even knew Cinderella existed. And then there is always in a fairy story the fairy godmother, and you see that here. And she came and found Cinderella, and with the wave of her magic wand, she transformed Cinderella from this little nondescript, unnoticed girl into a princess, because her dress and everything was different, and then everybody noticed her. And in the end, the prince noticed her and she married the prince. Okay, now on the bottom left-hand corner, we have some pictures, and they belong to the normal salivary gland on the left, FNAC of a salivary gland tumor in the middle, and the histological picture of a salivary gland tumor on the right. And there it says the Cinderella cell. Now we will find out why there is a certain cell in salivary gland histology which is referred to as the Cinderella cell. Well, I refer to it as the Cinderella cell. It's not written in the textbooks, so if you go looking for it in the textbooks, you won't find it. But why, given the fact that we know the Cinderella story, which cell is it in salivary gland histology and pathology that is referred to as the Cinderella cell, and what is its importance? So thank you very much, Chetan, for telling everybody the Cinderella story, and just keep it in mind when we are doing salivary gland pathology, okay? Right. Now, what I'm going to tell you today in this approach to salivary gland tumors is, number one, salivary gland organization, right? You cannot understand anything about salivary gland tumors unless you know how a salivary gland is organized. Then I'm going to tell you the importance of where a tumor occurs. Okay, there are some tumors that have a predilection for a particular site, and there are some tumors that never occur at any other site. So if we know that, it makes our life that much easier. Okay, then what is the significance of a preoperative FNAC of a salivary gland swelling? Perhaps today we won't do that, and at another time maybe we will do it. But there is a significance to it. I'm not going to show you any salivary gland FNACs. Then what is the role of frozen sections? How we come to the meat of the whole problem is, how do you approach the histological subtyping, because there are any number of salivary gland tumors. How do we begin to approach what this particular subtyping is? Then, of course, some ancillary techniques, and what is a comprehensive surgical pathology report. Okay, so let's start with salivary gland organization. And I'm going to tell you, just now, many of the participants were not there, but I was just talking to the students who are going to be your representatives, the audience representatives on this, on this slide discussion. And there is a difference when we use the word gland. There are anatomical glands and there are histological glands, okay? An anatomical gland is a gland like a salivary gland, a thyroid gland, an adrenal gland. The breast is an anatomical gland, and so on. There are many anatomical glands. And what do we mean by an anatomical gland? That this anatomical gland has the secretory element at one end. There is a whole series of ducts which collect the secretions, and then there is the terminal pore through which that secretion is poured into whatever. If it is the salivary gland, it's usually into the oral cavity, but you have mucus glands in so many different sites in the body, which are anatomical mucus glands, which pour their secretions through ducts into the trachea or into the bronchus or into various other structures. And these are anatomical glands, okay? But you have other glands, like the glands of the colon, the sebaceous gland, or gastric glands. They are only histological glands, okay? They don't have a ductal system. They have a simple glandular structure which just makes one or more secretions and throws them out into the lumen of whatever particular viscus they belong to. All right. So we are talking now about an anatomical gland, that is the salivary gland. You agree with that, Chetan?
Yes, ma'am.
Yes. Bharti, do you have any questions about an anatomical gland versus a histological gland? So when,
No, ma'am.
as I was asked, you don't. Okay. So when we describe glands in histology, we are talking about the histological gland. All right. So now I'm talking about salivary gland organization, and we're talking about the anatomic gland. Okay. And it has a branching ductal system with secretory acini at one end. Now let me see if I can change my pointer. Yes. So here we have this actual secreting element of the thing, of the anatomical gland, and that happens to be the acinus. Okay. Now this acinus is at one end, and I haven't been able to show you the excretory duct at the other end, because you can't have the excretory duct in the same picture necessarily as the histological picture, because it is at the far end. It's like the Stenson's duct, which is the duct of the parotid gland that opens into the oral cavity, opposite the molar tooth in the upper alveolus. Okay, but in between these acini, and you can see this is a secretory. These acini are very blue. You know that this is the parotid, because you have acini that are full of secretions, which is not mucus. Okay, if it was mucus, it would be pale, or it would show you a vacuole in the system. Okay, so now you have the acini, and you have intercalated ducts. Do you know what the intercalated ducts are? Can anybody spot an intercalated duct over here? I'm sorry, but our annotation system does not work in the new Cisco WebEx. But if you look very carefully, you see these big pink ducts. Now those big ducts, which are lined by a very bright pink epithelium, are not intercalated ducts. They are referred to as the striated ducts. Okay, these striated ducts have a very oxyphilic type of cytoplasm. But on the other hand, you can see buried inside here, and if you can't see it, please stop me and say, where is it? And then I will put my laser pointer on it. Do you see this small little duct here? Can everybody see it? Chetan, can you see it?
Yes, ma'am.
Yes. Bharti, can you see it?
Yes, ma'am.
Right. What about Dhanashri? Can you see it?
Yes, ma'am.
Okay. Jupiter, Prachi.
Yes,
Meena,
ma'am.
if you can't
Yes,
see it,
ma'am.
yes.
Yes, ma'am.
Very good. I'm glad, and I hope the audience can see it too. Yeah, let me see if I can draw a line with this thing. Do I need?
Yes, ma'am.
Yeah, you can see it. Okay, pointer options. Let me take the pen. Okay, can you see this? I've marked it with a red spot. Can everybody see that?
Yes, ma'am.
Yes, ma'am.
Yes, I hope you can do, because that is an intercalated duct. Now, this intercalated duct is so inconspicuous that you hardly are able to see it. Now, I don't know if anybody else can spot an intercalated duct. The big striated ducts are very easy because they have so much pink cytoplasm. Okay, can anybody see here? There is another intercalated duct buried right here at the right hand side of this. Can you see that? Yes?
Yes,
All of you
ma'am.
can see it?
Yes.
Yes.
So
ma'am.
that is an intercalated duct. Okay, and its cytoplasm of the cells are extremely different to look at. All right, now let me go back to my laser pointer. All right, so I think everybody has got the point that you see acini, you see the intercalated duct, you see the striated duct, and then you will see at the other end a excretory duct. Okay, now why isn't this moving? There you are. You see this? I marked it now with this arrow. All right, and that's the striated duct, which has a yellow arrow. Okay, now that's as far as the major anatomical structures that you see in the salivary gland. But when you start to get to the high part, you will notice, and now you see this black arrow over here. Can everybody see the black arrow?
Yes, ma'am.
Very good. Chetan, what is that black arrow pointing out to?
Ma'am, actually, I cannot see the black arrow.
You can't see the black arrow. Can you see my cursor?
Yes, ma'am.
Can you see the black arrow now? If the cursor is going around it, people cannot see the black arrow. Bharti, can you see it?
Yes, ma'am.
Very good. Chetan can't see it, but you can. So tell me, what is the black
Yes,
arrow?
ma'am. Now I can see it.
Oh, now you can see it. Excellent, Chetan. So what is it pointing out to?
This is, ma'am, intercalated duct.
Intercalated duct. Yes. So the black arrow is pointing out to the intercalated duct, and this is the same picture as you saw previously. All right. But what I want you to notice over here is, or to understand, that every structure in this salivary gland, whether it is the acinus, the intercalated duct, the striated duct, or the excretory duct, all of these epithelial structures in the salivary gland all have a two-tiered organization. All right, they have luminal cells and they have abluminal cells. Now, it's next to impossible to see the luminal cells and the abluminal cells well, except in the striated duct. But every one of them has luminal and abluminal. All right, Prachi, what is the meaning of luminal and abluminal? Then I will point it out to you in the striated duct. What is the meaning of the word luminal and what is the meaning of the word abluminal? Prachi? Prachi, are you there? Prachi has disappeared? Well, this is the second time Prachi
Ma'am, the
has
duct surrounds lumen.
Sorry? The ducts, what? What is
Abluminal,
the
that
meaning of the word
uh,
luminal?
cells behind, the cells lies behind the luminal cells are
What is a luminal cell? All right, let's ask Jupiter. Jupiter,
Ma'am,
what is the meaning of luminal cell?
ma'am, towards the lumen cells line.
Yes. So in other words, the cells that are adjacent to the luminal space. Okay, so you have a lumen, and everybody, I hope, knows what a lumen is. It is a space. a space in which is lined by an epithelial layer. And that epithelial layer that lines the lumen, and let's take the example of this striated duct right here, where you can see my cursor. Yeah, there is a lumen. It contains some secretions, and there are cells which are these bright pink cells that are next to the lumen. Those are known as luminal cells. They are all epithelial cells because true lumina are lined by epithelial cells. Right, now, what is the meaning of abluminal? Meenal?
Ma'am, on the other side of the lumen,
So away from the
away
lumen.
from the lumen.
Right. So that, and you can see here this particular duct, which is the striated duct, which has this very oxyphilic cytoplasm in the luminal cells, has, can you see that here? You can see that there are 3 or 4 of these cells which are away from the lumen, and those are known as abluminal cells. Okay, and they are best appreciated in the striated duct. Yes, you will also see them in the excretory duct, but I can't show it to you over here because there's no excretory duct. But I want you to look at the intercalated duct, yes, and I want you to look at the acini. And I want you to see whether you see the luminal cells and the abluminal cells as a double or two-tiered organization. Okay, Bharti, do you see it like that?
In the striated, I could appreciate it, ma'am. Whereas
Yes,
in
that's what we said. And there's no
Yeah.
problem about the striated duct.
whereas in intercalated and in acini, it is not very prominent.
You know, they're not very prominent. I'm sorry, but I can't see it.
Yeah,
Okay.
it is not seen. Yeah, I see.
It's not seen, but we know that it is there. It's there. It is described, and they are there. So, what are these abluminal cells? And if you see what I have written over here, okay, the abluminal cells. All the luminal cells are epithelial cells without any kind of myoepithelial character. In other words, there are no contractile elements in these luminal cells, in the luminal cells. But once you get to the abluminal cells, and pay very good attention, the abluminal cells in the acini and in the intercalated ducts are myoepithelial cells. They are epithelial cells, but they have contractile elements, chief amongst them being actin, smooth muscle actin. Okay, so they are there, and their function is to contract and push the secretions which are being manufactured in the acini and transferred to the intercalated ducts into the striated ducts. Okay, now what about the abluminal cells in the striated ducts and in the excretory ducts? Well, the abluminal cells in the striated ducts are mainly basal cells. Okay, and very occasionally they are myoepithelial cells. Now, what does that mean, Dhanashri? What does it mean? What do we mean that the abluminal cells in the intercalated and acini, intercalated ducts and acini are myoepithelial cells, whereas those that are present in the striated ducts and the excretory ducts are basal cells? What do you understand by that, Dhanashri?
Contractile property is not present.
Very good. So they do not contain contractile elements. So here there is something that you all have to understand, that all basal cells are not myoepithelial cells, and myoepithelial cells are not basal cells. They're completely different, although both of them are abluminal in position. Do you understand that, Chetan? Have you understood it?
Yes, ma'am.
Yes. So all cells that are, around the luminal cells are known as abluminal cells, but they are not all basal cells and they are not all myoepithelial cells. So you cannot confuse the two, and it's very important when we come to salivary gland tumors. If there's anybody who's asking questions in the chat box, hasn't understood anything, or any of the 6 students who are here, if you have a question, please ask me now, because it's an extremely important thing to understand when we are going to the approach to salivary gland tumors. Now here is a diagrammatic representation, okay? So at one end of this whole structure of the salivary gland, you have the asanas, okay? And I want you to, and so you see this black line that is around. What do you think is the black line, Chetan?
Sept.
Huh? What is the black line? It's a septum.
Septum.
Come on now, Chetan, please. What is the black line, do you think?
Lobule.
Bharti, what is
It's
the
a
black
lob-
line?
Representing a lobule.
It's representing a lobule. This is a lobule, the black line. A black line can be a lobule, Bharti. A line can be a lobule. Jupiter, what is the black line? And anybody can write in the chat box.
Elastic or collagen
What
fibers.
did you say, Jupiter? I didn't hear you. What?
Ma'am, I didn't say.
You didn't say anything. Okay, you said, somebody said elastic. Who said
Elastic. Ma'am, Meenal, ma'am.
that? Meenal. Meenal thinks it's elastic. Why do you think it's elastic, Meenal?
Ma'am, elastic or collagen fibers are surrounding the
Elastic or collagen fibers? Oh. Take your pick, Meenal.
Ma'am,
Yes.
ma'am, it could be a basement membrane.
Prachi. Prachi is absolutely right. It is the basement membrane. So it's telling you something. What is this? What are we to understand about the basement membrane here, Prachi?
The cells are resting on it.
Ma'am, it is to help to differentiate between the in situ tumors and the
No,
invasive.
not at all. This basement membrane is being laid down by basal cells in the
Basal cells,
excretory
yes,
duct,
ma'am.
in the striated duct, but it is being laid down by myoepithelial cells,
Myoepithelial cells, yes, ma'am.
or in the intercalated duct and in the asana cells. So the basement membrane doesn't vary. But what cells are laying down the basement membrane is extremely important. Okay, so basement membrane of the asanas and of the intercalated duct is laid down by the abluminal cells, which are myoepithelial cells in these two situations. But once you get into the striated duct, you don't get myoepithelial cells, you get basal cells, but they also have the function of laying down basement membrane. And I want you to look at this cartoon really very carefully, because you see how well they have depicted these very bright pink oxyphilic cells, which are not seen in the luminal cells of the intercalated duct. And of course, here they're a kind of a bluish purple, because many asana cells of the parotid and some asana cells of the submandibular salivary gland, what are they called? They are serous cells, right? Because they have a serous secretion which is full of zymogen granules. The submandibular gland has some acini which are mucus in nature, and the main secretion of the other large gland, and that is the sublingual gland, is all mucinous. So you have a serous gland, that is the parotid, you have a seromucinous gland, which is a submandibular gland, and you have the mucus gland, which is the sublingual gland. All the minor salivary glands that you have all over the oral cavity, and also in the respiratory tract, are all mucus glands. You'd get no serous glands in that part of the, of the minor salivary tissue. Okay, so this is just a representation of what I showed you in the histological slide. Okay, and you notice that how the myoepithelial cells have been depicted. They are depicted as elongated cells, which have processes in one or the other direction of the cytoplasm, whereas the basal cells have been depicted as polygonal cells with centrally situated nuclei. All right, very good. Now I told you that we need to talk about the situation of these salivary gland tumors. Where do they occur? Now this was a very old study that was done by my students, Deepa Bandare and Sucheta Korejam. Very old. You see that they studied it from 1987 to 1995, a total of 675 salivary gland tumors. It's just to show you which is the most important salivary gland that gives rise to the majority of tumors, and that's the parotid. Okay? And the parotid does not give rise to more malignant tumors than benign tumors. That's why I've outlined it in red, because this study was done at Tata Hospital, and in Tata Hospital, obviously more malignant tumors would be referred to Tata Hospital, and that's why you see many more malignant tumors in the parotid gland. If you're working in a general hospital, you will see far more benign tumors in the parotid gland than malignant tumors, right? And then in the minor salivary gland, however, this is more or less true, that you get many more malignant tumors than you get benign tumors, right? Now, what kind of benign tumors and what kind of malignant tumors? Now, there is the most prolific benign tumor that you see is a pleomorphic adenoma. It's a very large number of pleomorphic adenomas. By far and away, it is the most common salivary gland tumor. Okay. Now, I'm not talking about where and what and so on, except to point out over here that the Wathen's tumor does not occur, and please listen carefully to what I'm saying, does not occur outside of the parotid gland. Okay, so please remember this, that you never make a diagnosis of a Wathen's tumor in the submandibular gland, in the sublingual gland, or in a minor salivary gland. A Wathen tumor only occurs in the parotid gland. All right. On the other hand, look at the malignant tumors. Okay. Mucoepidermoid tumors can occur almost anywhere. Adenoid cystic carcinomas, yes, do occur in the parotid, but the minor salivary glands are the places where you get the largest number of adenoid cystic carcinomas, right? But look again here at an acinic cell carcinoma, and notice that there is no other place except for the parotid in which you get an acinic cell tumor. All right, so you've heard of the Wathen's tumor, you only see it in the parotid. An acinic cell carcinoma is only seen in the parotid. And what about this polymorphous low-grade adenocarcinoma? Nowadays, they've removed the word low-grade. It is only seen in the minor salivary gland. So we never make a diagnosis of a polymorphous low-grade adenocarcinoma in the parotid, and we never make a diagnosis of it in either the submandibular or the sublingual gland. It is only seen in a minor salivary gland and usually in the intraoral minor salivary glands. Now, I've said what I have to say. All the others can occur more or less anywhere in any of the salivary gland. except like as you will see here, carcinoma X pleomorphic adenoma. Since pleomorphic adenomas are rare in minor salivary glands, you are going to see carcinoma X pleomorphic adenoma only in the major salivary glands. It can be parotid, it could be submandibular, it could be sublingual, but you don't see it in the minor salivary glands, because to get a pleomorphic adenoma in the minor salivary glands, it occurs not uncommonly, but certainly not as often as in the parotid and in the submandibular salivary gland. Now here is the current WHO classification of salivary gland tumors. It's a huge, long classification. There are some changes between this and the previous classification, and some of them I have just underlined. Okay, we used to call, I just told you, the tumor in the minor salivary glands a polymorphous low-grade adenocarcinoma. Well, now we just call it polymorphous adenocarcinoma. There was an entity called mammary analog clear cell carcinoma because it resembled exactly this mammary analog secretory carcinoma is down here, all right? Because it resembled the secretory carcinoma of the breast, and this is now just called secretory carcinoma in the salivary gland. But there was a hyalinizing trabecular carcinoma, clear cell carcinoma. The hyalinizing has been removed, and it's just called clear cell carcinoma. Okay. In the old classification, there was no intraductal carcinoma, and now it has been introduced. I have never seen an intraductal carcinoma in the salivary gland. Certainly, I didn't see it in the 600 odd tumors that we saw or studied. Perhaps at that time, since there was no entity at all, we didn't recognize it there. And then there is this entity called sclerosing polycystic adenosis, which we don't know if it is a true adenosis or it may be a kind of adenosis tumor. Good. So this is, and if you want to find out or to read about the new update, you can read it here in this journal called Head and Neck Pathology. And there is a, it has been written by Alina Skalova, who is a very famous Czech pathologist who really described this secretory carcinoma because she noticed how similar it was both in its morphology and its molecular makeup to the mammary tumor. And she had coined the term mammary analog secretory carcinoma. Now it's just called secretory carcinoma. Okay, so this is the update, and you can sort of see it. Now I've put up this cartoon, and you might think, now this looks exactly like the previous cartoon. Why is it being shown again? Well, it is being shown again because I have marked here all the different tumors that arise from the different or are related to the different parts of this salivary gland assembly. It makes sense that the acinus, the acinic cell carcinoma resembles the cells of the acinus. Okay. Now here is the intercalated duct, and that intercalated duct is very prolific in the number of tumors that seem to arise from the intercalated duct, or at least show differentiation towards intercalated duct structures. Chief amongst them is the pleomorphic adenoma, right? The adenoid cystic carcinoma has a resemblance to the intercalated duct. Then this polymorphous low-grade adenocarcinoma, that has a resemblance to, or the histogenesis is from the intercalated duct. And all myoepithelial tumors seem to arise from the intercalated duct. And you see, notice here, myoepithelial cell. Yes, this myoepithelial cell is involved in the tumor, in the pleomorphic adenoma, adenoid cystic carcinoma, polymorphous low-grade carcinoma, and of course in myoepithelial. So all of these tumors have got a myoepithelial component. Yes, now when you come to the striated duct, do you remember how we emphasize the fact that it has very oxyphilic character? Okay. Now, Dhanashri, you want to tell me what do we mean when we say oxyphilic? What is oxyphilic? I've been saying it, no? Now I must have used that term at least 5 or 6 times. So what is oxyphilic? And where do we use this term? Yes, tell me, Dhanashri. Yes.
More pink.
More pink. Anything else? Think of the thyroid, Dhanashri. When do we call something oxyphilic in the thyroid? Can you think of it? No? Prachi?
Yes, ma'am. The more eosinophilic cytoplasm.
Yes, I know that. But it can't be just eosinophilic. There are so many eosinophilic.
Degenerative.
Oh, it's got nothing to do
Cells.
with degenerative. The most
Like
pink
accumulation of
cytoplasm of all
mitochondria.
in the body is what, Prachi? Which is the most pink cytoplasm in the body? Which is the brightest pink cell in the body? Anybody writing it in the chat box? Now, Prachi, you know that it's the muscle cell, right? Whether it's a smooth
Yes.
muscle cell or it is the skeletal muscle cell, it's very brightly eosinophilic, but we don't call it oxyphilic. So what is this oxyphilic? Has anybody mentioned it in the chat box? Yes?
People have mentioned as Hurdle cell.
Yes, so Manali, tell me, what are they saying?
They are saying Hurdle cell and cells
Yes, very good. What else?
meaning of oxyphilic they have mentioned as pinkish with abundant cytoplasm, eosinophilic.
And granular. So it's abundant eosinophilic and granular cytoplasm. Hurthle cells have it. And Hurthle cells are known as what in the thyroid?
Oncocytes.
Escanases.
Exactly.
Oncocytes.
So it's these striated duct cells are so pink, so granular, so oxyphilic, and it is no great surprise, therefore, that the oncocytic tumors, Warthin's tumor, if it is in the parotid gland, and you get other oncocytic tumors in the, but not associated with they're not papillary, they're not bi-layered. There are other oncocytic tumors that occur in other salivary glands or even in the parotid, but not the distinctive Warthin's tumor. All those oncocytic tumors, including the Warthin tumor, arise from the striated duct. So you should never forget that. The striated duct has got such a pink cytoplasm, which is oxyphilic, and they give rise to oncocytic tumors. Now we come to the mucoepidermoid carcinoma, the ductal adenocarcinoma, squamous carcinoma, other tumors which arise from the excretory duct. Okay, so now let's just quickly go over this. The acinus is related to the acinic cell carcinoma. The intercalated duct is related to the pleomorphic adenoma, the adenoid cystic carcinoma, myoepithelial tumor, epithelial myoepithelial tumor, tumors, polymorphous low-grade adenocarcinoma, oncocytic tumors to the striated duct, mucoepidermoid, squamous, and ductal adenocarcinomas to the excretory duct. Okay, so everybody has got a good idea of this, the relationship to the different parts of the salivary gland unit. All right.
Yes,
So now we see what happens under conditions of neoplasia. It's another way of saying to you what I said in the previous slide. Okay, now you can see here the ductal lining cells, the acinar cells, the striated duct lining cells, etc. So the luminal cells, when they appear under conditions of neoplasia, can show you ductal lining cells, oncocytic cells, acinar cells. There may be even sebaceous differentiation, squamous cells, and mucinous cells. Okay, all of these can be found, the kinds of avatars of the luminal cell under the conditions of neoplasia. Now let's come to the other cells, the abluminal cells, and mainly the myoepithelial cells. Yes. Now the myoepithelial cells. Now you have about 1, 2, 3, 4, 5, 6 different kinds that are present, cells that are related to the luminal cells. Now you want to see the really huge number of cells that are related and types of stroma that are related to the myoepithelial cells. You have the plasmacytoid cells, the hyaline cells, mixochondroid cells, squamous cells are not only related to luminal cells, myoepithelial cells give rise to squamous differentiation with or without keratin. Then there is this whole myoepithelial mantle that gives rise to clear cells. You may see them in sheets, in trabeculae. They may form cribriform patterns. There are spindle cells, and there's the production of pink hyaline material. So it's not just mixochondroid and hyaline material, which is basement membrane. You might even get frank cartilage, and you can get bone. So all of these seem to be related to the myoepithelial cell. Okay, so now can Chetan, you knew the Cinderella story, right? So
Yes, ma'am.
now can you relate this Cinderella story to whatever we're seeing on the screen? Because the myoepithelial cell I call the Cinderella cell. Why do I call it the Cinderella cell, Chetan? Why do I
Because
call it the Cinderella cell? Yes.
it has many faces or many types.
Many types. That's the reason. Chetan, you told me the story so well. So why am I calling the myoepithelial cell the Cinderella cell? Bharti?
When the circumstance arrives, it changes its morphology, the
Aha.
appearance.
Yes, so say it properly, Bharti.
The character of the myoepithelial cell is getting changed.
It changed.
Under-
That's all that is the reason that we call it the myoepithelial cell. Dhanashri? Bharti is partly right. But what is the point that Bharti has missed?
The appearance.
Appearance, she said, that it changes its appearance.
Its
Now,
function.
Prati,
Ma'am,
What
it
is the
changes
point?
its differentiation.
changes its differentiation. No, Prachi. Jupiter. Yes? Anybody writing it in the chat box? Manali?
No, ma'am.
No. Meenal?
No, ma'am.
No. What did I show here? Huh? There's an arrow that's going from here to here. So what is it telling you?
Transformation.
Supporting cell to
Huh?
Mm.
From
Me.
what? Supporting cell. No.
It's a
Into
transformation.
Is that, and you can see it in the picture here. Can you see a myoepithelial cell? Are you able to recognize a myoepithelial cell under normal good histology?
No.
so from
No.
inconspicuous to it
You
is
can't
becoming
see
Didn't
the
put attention.
myoepithelial
Yes.
cell. All right, like Cinderella, nobody saw, noticed, or even remarked on Cinderella because she was just a
Invisible.
nobody. Okay, so a nobody cell, a cell that you cannot even see even when you're straining to see, suddenly under conditions of neoplasia, when the fairy godmother waved the wand, it's like the wand of neoplasia. You know what is a wand? No, it is one of those fairy sticks that the whole myoepithelial cell gets transformed. And then whether you like it or not, you just recognize, or you cannot help but see this wonderful, all the wonderful avatars of the myoepithelial cells. So Chetan, will you tell me again, why is the myoepithelial cell called a Cinderella cell?
Because earlier it was invisible in normal histology.
It was invisible,
And
and now?
it was, and now after the many transformation,
Ah.
it could be visible.
So you see, that is the real essence of a myoepithelial cell. It's Cinderella until it's suddenly, its whole, it gets so transformed that it can take so many, it's like a ball gown with sequins and bows and, lovely colors and everything, from a nondescript cell, which you do not or you cannot even notice. The myoepithelial cell, under conditions of neoplasia, becomes the Cinderella going to the ball. All right, now has everybody understood that? Have they said anything in the chat box? If they haven't, then they'll have to.
Yes, ma'am. Now many
Yes, now what?
students have written in the chat box
They
as
have.
myoepithelial cell is initially inconspicuous
Right?
and later it appears, it changes its shape and function.
And becomes extremely conspicuous.
Yes.
Very good. So that is the myoepithelial cell, and this is the the story of salivary gland tumors. And why is it the story of salivary gland tumors? I will tell you. Salivary gland tumors can be divided into two major groups, and I've got them on the left hand side and on the right hand side. Now let me ask you, what is the difference between the tumors that are present on the left hand side and the tumors that are present on the right hand side? Come on, Meena. What is the difference? Look at this, all of the tumors one by one, and tell me there is one major difference between the tumors on the left hand side and the tumors on the right hand side.
Left hand side, the origin is from intercalated ducts.
The left hand side is from
Most
the
of-
intercalated ducts. Acha, very good.
And
Yeah, Prachi.
Yes, ma'am, same here. The left hand side has having intercalated duct origin.
Intercalated duct origin. Jupiter.
The left-hand side has myoepithelial cells, it's the basal cells, and on the right-hand side has
No. What?
the basal cells.
Myoepithelial cells are?
Ma'am, on the left-hand side, myoepithelial cells are present mostly on the
Okay.
basement membrane, and on the left-hand side, the basal cells are present.
On the right hand side, there are no myoepithelial cells. Absolutely right, Jupiter. There is one major difference, and yes, it just so happens that they are from the intercalated duct. But this is the major difference. And what's that major difference? All of the tumors on the left hand side have got myoepithelial cells, and there are no myoepithelial cells on the right hand side. A Wathin's tumor has got a luminal and an abluminal layer. No, it's a double layer thing, but that happens to be basal cells. There are no myoepithelial cells. Mucoepidermoid tumor has got no basal cells and no myoepithelial cells. An acinic cell carcinoma has got only acinic cells, no myoepithelial cells, no basal cells, because they never have basal cells. Similarly with the duct carcinoma or any other adenocarcinoma that is from the, which is from the excretory duct or the striated duct, secretory carcinomas and hyalinizing trabecular carcinomas, or which are known as clear cell carcinomas now, they are all from the from areas where there are no myoepithelial cells. Okay, this is not trabecular. This should be hyalinizing clear cell carcinoma. Very good. So that is the main difference. And now, this is all that you need to know for the approach to salivary gland tumors. You have to ask yourself a question. Does this tumor, when I'm looking at it, does it have myoepithelial cells? Or it has no myoepithelial cells? If it has myoepithelial cells, it belongs in this category. If it has no myoepithelial cells, then it is in the other category. Okay, so when we start, just a brief word about preoperative diagnosis of salivary gland tumors, okay? We do it normally by fine needle aspiration cytology, and we have to have a good clinical examination to make certain that whatever is presenting in the salivary gland is actually of salivary gland origin and not something that is presenting in the salivary gland but is coming from somewhere else. And why do we say that? Because you have some deep-seated lesions which appear as if they are from the deep lobe of the parotid, but they may be coming from other, they may be tumors of other structures in the parapharyngeal space. Okay, so we need to know this, and we do it by fine needle aspiration cytology. And these are all the different areas where you see salivary gland that are present. Okay, the major salivary glands are there. You have the minor salivary glands, which are mainly intraoral. Okay, you must remember this, that not every swelling represents disease of the salivary gland. There may be other kinds of diseases, particularly those that involve the lymph nodes, because lymph nodes are very often, not so much with the minor salivary glands, but with the major salivary glands, there are lots of lymph nodes that are present around the submandibular and the parotid glands, and you have to be careful that sometimes it's the lymph nodes that are producing the salivary swelling. Okay, the second thing is, not all salivary disease is neoplastic. You get cysts, you get sialadenitis, etc. And so we aspirate salivary gland swellings first to rule out diseases other than the salivary gland, then to try to rule out neoplastic disease separate neoplastic disease from non-neoplastic disease, and only last to subclassify salivary gland neoplasms, because you should not assume that every salivary gland swelling is a salivary gland tumor. Okay, so we get lots of clinical mimics, and I've just told you that you can have lymph node enlargements, which are quite often metastatic squamous carcinoma or sebaceous carcinoma, lymphomas, infections, and so on and so forth. We won't belabor this point. So when you're talking about a preoperative diagnosis, the first thing you do is separate salivary from non-salivary pathology, because if you believe that everything is a tumor, then you're going to miss a whole lot of non-salivary pathology. Salivary neoplasia from non-neoplastic salivary disease, and finally the subtyping of salivary gland neoplasms. All right, and this is just to tell you that's not easy on FNAC. I'm sorry, this should be FNAC, to be accurate about what subtype of salivary gland it is. And when I mean accuracy, I mean it's a pleomorphic adenoma, it's called a pleomorphic adenoma. It's an adenoid cystic carcinoma, it is called an adenoid cystic carcinoma. And it is not it's not a very accurate way. So now let me ask you this question. What is the clinical impact of an inaccurate preoperative subtyping of salivary gland tumor? We know it's a salivary gland tumor, but we've got the subtyping wrong. I've called a pleomorphic adenoma an adenoid cystic carcinoma, or I've called an adenoid cystic carcinoma an epithelial myoepithelial tumor. So does anybody, and let anybody write in the chat box as well, what is the clinical impact? Is it none? Is there some impact? Or is it huge? Anybody amongst our students wants to try? Yeah, Jupiter? Does it make a huge difference?
No.
No? All right,
Yes.
Jupiter, you say no. Prachi?
No, ma'am.
No? Okay, very good. Meenal? Because you're saying no, I'm going to ask you soon why. Meenal? What, Meenal?
Ma'am, it might have some impact.
It might have some impact. So Meenal is sitting on the fence. The Jupiter and Prachi think that it has no impact. Okay. What about Dhanashri?
Ma'am, there will be some impact.
Some sitting on the fence. Bharti,
It has a huge impact, ma'am.
it has a huge impact. Okay, and Chetan?
Ma'am, it has a huge impact.
All right. So we've got two fence sitters who say some, two who say none, and two who say huge. What is it in the chat box, Manali?
40% for huge, 40% for none, and around 20% for
For
some.
some. Okay, wonderful. Now I'll tell you what it is. It's none. So I don't know, Jupiter and Prachi, you said none. Okay, can you tell me why? Why?
Ma'am, it is
Hmm?
maybe it is because of it is pre-op subtyping.
So that's
When we
why.
are getting this specimen, we can accurately tell
Get the
what.
specimen and then we can do it. So if I call a malignant tumor benign on FNAC, you mean it doesn't matter at all? Why? You don't think that the surgeon might want to have done something more? Huh? Yeah, maybe he would want to dissect the lymph nodes. What do you think, Prachi? And Jupiter? I'm telling you it's none, but what did you think it was? Yes, Jupiter?
Ma'am, because there will be complete removal of the gland.
Oh, really?
Uh,
And so you don't think it matters about the dissection of the lymph nodes?
Ma'am, it will matter.
Then you should have said some. Well, let us find out now why I say that it has little or no impact. Well, first of all, you cannot answer this question. Nobody can answer this question unless you know how anybody manages a salivary gland tumor. Okay, so you should know that. And if you don't know that, then you have no right to answer. Okay, now in the parotid gland, they will do a superficial parotidectomy or a total parotidectomy, not depending on depending on where the location is. Okay, if it is in the superficial lobe of the parotid, I hope you know that there are two lobes of the parotid. One is superficial and one is deep. Okay, so they will do this superficial parotidectomy or total parotidectomy depending on where the tumor is located. Okay, and you know that the facial nerve is running through that through the parotid gland, and if it is not paralyzed, then they will try and spare that facial nerve, and they will try and replace that facial nerve. That's called a graft. They will put a cable graft if necessary. Okay, if it is totally paralyzed and nothing can be done about it, then they remove the facial nerve as well. Okay, you might do a partial excision for the lower pole lesions. And as I said, you can say they do a nerve sacrifice with engraftment, that is a cable graft, whenever it is feasible. What do they do for submandibular gland? They do total excision. Okay, there's no such thing as partial excision of the submandibular gland. And in the minor salivary gland, they do wide excision with clear margins. Okay, but what is important about this is they do it irrespective of the histology. It doesn't matter whether it is benign, it is malignant. If they knew that it was benign or malignant beforehand, whatever kind of malignant tumor, they are going to do surgically the same thing. Okay, you've got a malignant tumor in the superficial lobe of the parotid. They are not going to take out the deep lobe, right? They are going to do the same thing, and that is a superficial parotidectomy. If a tumor is situated in the deep lobe, then to reach the deep lobe, you have to remove the superficial lobe. Okay, so then you do a total parotidectomy. But this does not depend on the type of tumor. So remember that the surgical management of salivary gland tumors is the same whatever the tumor is, benign or malignant, low grade or high grade. Okay, Now, somebody will ask me, which I was asking you, what about a lymph node dissection? And the answer is simply this. They will take out clinically positive lymph nodes. That means they will do a neck dissection. Now, as far as a prophylactic neck dissection, it is extremely controversial. Some people might do a neck dissection. And what is the meaning of prophylactic? Come on, Chetan, what is a prophylactic neck dissection? Huh?
The lymph node is not affected, still there.
Yes, and how do you know it's not affected? Because it is not palpable, okay? So an affected lymph node is usually palpable. If it is palpable, you call it a clinically positive node and you will take it out. But if it is not palpable and they can't feel it, then it is what is called a clinically N0 neck, zero metastasis in the neck. And then the question is, should you take it out? And that is a very controversial thing. Sometimes it is advocated for high-grade tumors. And high-grade tumors, it doesn't matter what that tumor is, as long as it is high-grade. And I think you'd have to be blind if you couldn't see high-grade morphology on an FNAC. It didn't matter what kind of high-grade it was. Yes, then you could tell them that this is a high-grade malignant salivary gland tumor, and they will do whatever they have to do, superficial parotidectomy or a submandibular gland excision, and they will dissect the the regional lymph nodes if they have to. Have you understood? This is the management of salivary gland tumors. It does not depend upon the type of the tumor. It might depend on the grade of the tumor. Okay, so if we had to encapsulate that in 3 sentences, it is that histology has virtually no impact on primary management. The grade may detect prophylactic treatment to the N0 neck. Grade and stage, not histology, determine the prognosis. Now, this is another very important fact that you have to remember. Okay. So then why should we subtype preoperatively? Then why are people poking salivary glands? Why do you have to learn in your cytology classes, have cytology slide seminars on how to identify salivary gland tumors? You have or you don't have? Yes, Chetan? Everybody's poking needles, right? So why should we do it if it has no impact on management? Yeah, Chetan? Bharti? Dhanashri? Jupita? Anybody writing it in the chat box?
Recurrences, follow-up. There are many things other than surgical excision, Om. There are chance of recurrences.
Recurrences.
Chance of recurrences and
Chance
follow-up.
of recurrence, that in any case it happens after you take out the main thing, no?
Then
Cause of
follow-up,
swelling.
follow-up. Follow-up.
FNAC basically
Follow
done
up.
is it.
Follow up. What are you following up? Why are we
patient's
subtyping
following.
preoperatively? I'm talking about preoperatively.
For
Follow-up
grading.
is post-operative. Yeah.
The
For
swelling.
grading.
For grading, we grade on FNAC or we grade on the main specimen. Huh, Bharti?
So then it is basically benign versus malignant, ma'am.
No, but we don't need to know that. I told you, whether it's benign or malignant, you'll do the same surgery, Bharti.
And
So
for
why should we subtype? Yes, Dhanashri.
Whether it is of
yes, ma'am.
Yes, whether it is of salivary gland origin or not,
Origin.
that is fine. But I'm talking about subtyping of salivary. I know that it is a tumor. Now I have to subtype it. I've gone past that stage when I know that it is of salivary gland origin. I know that now I know it is neoplastic. And now the question of subtyping it. So I've reached the stage of knowing that it is a salivary gland neoplasm and I have to subtype it. So why? Come on, it's common sense. Huh?
not all
Prachi?
needs excision.
Well, You might think, what's the meaning of this? To train the pathologist's eye. Why should the pathologist's eye be trained if that is never going to be actually used to subtype salivary gland swellings? Okay, now common sense tells us that this is fine if you're going to do surgery on the tumor. What if you can't do surgery on the tumor? All right, because the patient either is too old, too bad a risk for surgery. Yeah. So don't you want to know what you are leaving behind? So it's important information of knowing what is in that, what is the subtype of that salivary gland tumor when surgery is risky or it is not possible. Then I want to know, if I'm going to take the risk, how important is that risk? If it's a benign tumor, why should I take the risk of that surgery? Yeah, if it is a pleomorphic adenoma, if it is a Warthin's tumor, I don't want to take the risk of surgery. I might as well leave it alone. Okay, but if it is malignant, and that too if it is highly malignant, then if there is a risk, I will take that risk. Okay, so this is what, and that's why we should train our eye. We should never let any chance go to not do an FNAC of a salivary gland tumor, because we then compare it day in and day out with every salivary gland tumor that I have FNAC'd. I'm comparing it with the histology, so that in that one or two cases in which surgery is not possible and an FNAC is done, I know exactly what that tumor is, and then the surgeon can decide whether he should take the risk of operating on that tumor, or it's benign, or it is so low grade that it can be left behind. Does everybody get the point now? Yes,
ma'am.
Yes,
Chetan?
ma'am. Yes,
Yes,
ma'am.
ma'am.
So if you don't train your eye, then you are never going to know what that tumor is when you really need to know what that tumor is. I hope everybody has got the point, and even those who are listening and writing in the chat box. Okay, so what is our diagnostic algorithm? First is FNAC. Then we decide whether this is of salivary gland origin or non-salivary gland origin. Okay. If it is of salivary gland origin, we need to know, is it neoplastic or it is non-neoplastic? Is it sialadenitis? Is it a simple cyst? If it is neoplastic, the next question we ask is not what is its subtype. We ask, is it primary or metastatic? And that is true of any tumor, not just salivary gland tumor. It may be a tumor in the lung, it may be a tumor in the liver, it may be a tumor in the retroperitoneum, it may be anywhere. You first, after you know that it is neoplastic, you ask, is it primary or metastatic? And to give you an example, if I have a clear cell carcinoma, and it is, I know it is a clear cell carcinoma, it is there in my parotid gland, I cannot assume that that clear cell carcinoma is arising in the parotid, okay? Because many renal cell carcinomas have been known to metastasize to the parotid gland. So I should then have my antenna up, the flag should go up in my head, and I should say, this is a clear cell carcinoma. I should ask, has anybody examined the kidneys? Has anybody done a PET scan, CT scan, anything, ultrasound? And it's amazing, maybe 1% of the time, you will have hit the right diagnosis, and this is actually a metastatic carcinoma. So never forget to ask the question, is it primary or metastatic? After you have decided that this is a primary neoplasm of the salivary gland, then you divide it up into benign, malignant, or I don't know. I can't tell the difference between benign or malignant. Okay, if it, you know, it's a pleomorphic adenoma, you are able to detect that this is a acinic cell, or you're able to say that this is adenoid cystic or whatever, that's fine. But if you can't tell the difference, then most of the time, that is because it's low grade. You will never mix a high grade tumor and say, I don't know. Of course, a high grade tumor is always malignant. Okay. So once you have made up your mind whether it's malignant, even if you can't subtype it accurately, at least you should say whether it is high grade or you think that is low grade. Okay. That makes a lot of difference to whether or not they will dissect the nodes, or at least make a decision as to whether they dissect the nodes or not. Okay, so this is the diagnostic algorithm. Never forget that intermediate step which says primary versus metastatic. Okay, very good. Now, what is the role of frozen section? I don't encourage it. Some people do it. It's sometimes you don't know whether it is a possible non-salivary disease, and a frozen section might help you in that. Yes, it sometimes helps you in the tumor type and the tumor grade. It also helps you to decide whether there is facial nerve involvement, because the patient may not be, the nerve may not be paretic, but are there small deposits on the facial nerve which they need to remove? So they send you little bits and pieces to ask, is this fat? Is this just scar tissue? What is it? But most important, it is the status of the lymph nodes. Okay. So should they do a major lymph node dissection or not? That is the main role of frozen section in salivary gland tumors. As I said, it is not very helpful if an FNAC has been done before and you know more or less how to, or the surgeon knows more or less how to proceed. Okay, so now we come to the diagnostic approach to salivary gland tumors. I've already told you how we go about salivary gland tumors, how we have to think about them in our minds. And this is the diagnostic approach. This is it. Are there myoepithelial cells in the tumor? Can I recognize myoepithelial cells? Or are there no myoepithelial cells in this tumor? Now, what is the next question, Chetan? That now I have told you this. Now, what are you going to ask me, Chetan? What are you going to ask me? Yes, madam, you've told me that I should recognize whether there are myoepithelial cells or not. So, any questions are forming in your mind, Chetan? No? Anybody, Bharti, have you got a question in your mind? Or Jupiter, or Meenal, Prachi, Dhanashri? I've told you, look for myoepithelial cells and you either see them or you don't. There's no question formed in your mind? What?
If it is not myoepithelial cells, then what is the cell of origin?
Oh, no, certainly not. Any question? Hey, if I were listening to this lecture, you know what would be in my mind? Okay, that's very good. You're telling me look for myoepithelial cells and then divide up the tumors into those that have and those that not. So what's the question that I would be asking in my mind to the lecturer? I would be saying, hey, tell me, how do I recognize a myoepithelial cell? Yes or not, Bharti? The question didn't come to your mind. Huh? That is the question that would come or should have come to everybody's mind. Which means that you are just sitting there. You're not thinking about whatever is being said. You're just saying, जो कुछ हमें बताएंगे बस so ठीक है. No. If you are following the trend of thought, I have told you, divide up tumors into those with and without myoepithelial cells. The next question should have come to each one of you and all of the whole audience that is there. Are Baba, but tell me, how am I going to identify a myoepithelial cell? Isn't that the question that should come to your mind? Yes or no, Jupiter?
Yes.
Yes, sir.
So now I have reached a stage where I am not only giving you a lecture on salivary gland tumors, I'm giving you a lecture on how you should think. This is to me incredible. Okay? I have to now get into your heads and ask the questions that you are supposed to ask. Please, you cannot learn unless you do this actively. You cannot sit there and be passive listeners. Okay? You have to be active. Your mind has to be active, Bharti. Do you understand or not? Prachi?
Yes, ma'am.
Yes,
So I'm telling you to do this and you're not asking me the question, but how should I do it? And I'm asking you to ask me a question. Okay? So I feel that you guys just sit there and do no work. Okay? So the first thing that we do when we look at salivary gland tumor, is it monomorphic or is it pleomorphic? The real word should be polymorphic. Why? Because pleomorphic is a word that we often use for very high grade tumors that have bizarre nuclei and bizarre shapes to the cytoplasm, spindle and stellate and all sorts, all mixed up. That is the way that we use the term pleomorphism. Yes or no? Yes, Chetan?
Yes, ma'am.
Yes. But we happen to use it for the most benign of salivary gland tumors. We call them pleomorphic actins. If I had the right to change the thing, I would call it a polymorphic, as the opposite of monomorphic. Okay, that it has multiple different cells, not just shapes, multiple different types of cells and multiple different types of stroma. So truly speaking, the word should be polymorphic, but we have to use the word pleomorphic because that has been sanctioned by parampara from God knows which jamana, that is pleomorphic. Okay? Right. Now, we have to recognize or suspect that there is a myoepithelial and sometimes a basal cell component. But let us just stick to the myoepithelial component. Okay? Number one, many myoepithelial cells have a basaloid appearance. Okay? What is the meaning of basaloid? Dhanashri, what is basaloid?
Basiloid is cell with scanty cytoplasm.
Very good. Yes.
And mostly it is nuclear.
That means there is a very high nuclear cytoplasmic ratio. Yeah, then they don't have to be big cells. They are usually small to medium sized cells with very little cytoplasm. You're very right, Dhanashri. And they're mostly cuboidal. Okay. So they're cuboidal cells with little cytoplasm, and the nucleus occupies a large part. Obviously, otherwise there would be lots of cytoplasm. Okay. So that's one characteristic of myoepithelial cells. It doesn't mean other cells may not have it. Certainly basal cells also have a basaloid appearance, okay? But that is one thing in which you can suspect myoepithelial, that this may be myoepithelial. Then a variety of matrices, that means different kinds of matrix. Chondroid, myxoid, hyaline, bone. Any or all of these matrices, when they are formed, they are not formed by other cells. Okay? Hyaline matrix may be formed by a basal cell because, as I told you, whether it's a myoepithelial cell or a basal cell, it does produce basement membrane. And this hyaline material is usually basement membrane. So some cells, some tumors rather, that have a basal cell component may have a hyaline, but not chondroid, not myxoid, not bone, okay, or myxochondroid. So when you see a lot of matrices, you suspect that there may be a myoepithelial component. Then these are very characteristic. they're hyaline or plasmacytoid cells. We'll see some examples. Spindling is another time when you suspect that this is a myoepithelial cell. Okay, clear cells, that's another time. But clear cells are not always myoepithelial. You see clear cells in a mucoepidermoid tumor, you see clear cells in an acinic cell tumor, you see clear cells in many different tumors. But if you get a monomorphic population of clear cells, you might want to consider myoepithelial in origin. But how are the myoepithelial cells placed? They often form indistinct borders of cell groups. You can't take a pencil and draw a line around it. Even, I mean, nobody goes on a slide and draws pencils, but takes a pencil, but you get that appearance and we'll see it. Then there is this thing called adenoid structures. And we said that adenoid cystic carcinoma is a carcinoma that has adenoid structures. So what are these adenoid structures? We'll have to see that. And finally, see what I wrote there. Keratinizing squamous elements. I'll tell you something. If anybody asks, do you get squamous elements in tumors? And the answer is, yeah. And if I ask anybody, give me an example, then I'll ask you. Why should I ask anybody? Chetan, tell me, where do you get squamous cells in which tumor? In the salivary gland? Something that you are familiar with? Yeah? Can you tell me any salivary gland tumor? Forget about whether they are myoepithelial or not. Tell me
In
a
what?
tumor. Yes?
In Watson tumor.
In a Watson tumor. You get squamous cells in a Watson tumor. Chetan, are you listening to yourself? No. Bharti? Name one tumor with squamous cells in it.
In mucoepidermoid.
Squamous cell carcinoma.
Very good. Yeah,
Man,
squamous cell carcinoma,
mucoepidermoid.
yes. Mucoepidermoid tumor. No?
Mucoepidermoid carcinoma.
Correct. It has squamous cells in it. I'm glad that you brought up mucoepidermoid tumor because I have to tell you something about a mucoepidermoid tumor, which I will say here and I will keep on repeating it throughout this term and the next thing on salivary gland tumors. And you know what that is? The true mucoepidermoid tumors, and I mean true, that somebody has not made an error, never show you keratinization. So there is no mucoepidermoid carcinoma that shows keratinization. And I'll repeat it again. Mucoepidermoid carcinomas do not show keratinization. So the moment you see keratinization in a tumor, and it is not a frank squamous carcinoma, it's not a high-grade adenosquamous carcinoma, it's not a duct carcinoma that is high-grade, which also shows you squamous elements, and you see keratinization, it cannot be a mucoepidermoid tumor. It probably is a tumor that has myoepithelial elements, because myoepithelial tumors or myoepithelial cells in a tumor often show you squamous metaplasia, and that too keratinizing squamous metaplasia. Okay, now please get that straight. All right, now the next thing that you should be noting, are there lumina in a tumor? Okay, and are these true or false? The false ones are the adenoid structures. If there are lumina, what kind of luminal secretions? There mucin in the individual cells. There may be mucin in the lumen, but the mucin in individual cells is there. Do you see oncocytes or granular cells? Is there any cellular atypia? Are there very obvious malignant characteristics? When you're looking at the boundaries of the tumor, is there frank invasion? Is there circumscription? And what is very important is central dense hyalinization with or without calcification and ossification. And this is not about the matrix of the tumor. It is that you have a tumor all around, sitting right in the center, you get a dense area of hyalinization, calcification, and ossification. And why should you note it? Because this is a sure sign that this tumor has been there for the longest time and it is now turning malignant. So when a pleomorphic adenoma has been there for 15 years, 20 years, and now it is beginning to show facial weakness, pain, or even rapid growth, that tumor in the center will show you dense hyalinization and ossification, right? So even if you don't see any remnant pleomorphic adenoma, you can be sure that this tumor is a carcinoma X pleomorphic adenoma, all right? So this is what I term the diagnostic approach. And what is the important thing is, can I recognize or suspect that there is a myoepithelial? The basal cell component won't show you some of these things. Some of them, yes, some hyalinization and a basiloid appearance may be seen in any tumor that might have basic cells, okay? All right, now what are you seeing over here? Come on, Meenal. Meenal has been quiet for some time. Can you just tell me, based on whatever I just told you, do you think this tumor has got myoepithelial cells? Now let's just practice that. Chalo.
Yes, ma'am.
It has. Very good, Meena.
Yes, ma'am.
I agree with you. Why do you think it has got myoepithelial cells? You can't say yes, ma'am, and not explain it, okay? That is not allowed. Come on.
Ma'am,
You said yes. I'm agreeing with you. Now tell me why you said yes. Why? Why, Meena? Now you can't say yes and not tell me why. If you said yes, it is because you recognized that there were myoepithelial cells and you just didn't take a shot in the dark. All right, think about
I
it.
recognized, ma'am.
Yes, sorry, Meena, you were saying something. What? What did you say?
Ma'am, I could recognize the myoepithelial cells, ma'am.
How did you recognize it? Why do you think they're myoepithelial cells? There has to be a reason, right, Meena?
Yes, ma'am.
Yes, so tell me the reason. You can't get away with saying, tell me. Number 1,
Slightly,
2, 3, 4, 5. What are the reasons?
ma'am, they are little elongated or like spindle shaped.
All right. So Meenal says that she recognized the oval or spindle shaped cells that are seen here. Certainly they are. Okay. You can see these spindle shaped cells which are there with oval. There are some with oval nuclei. Excellent, Meenal. Now, what else? What else? So that's it. Bas. On that basis, you said that there are myoepithelial cells. I'm sorry, Meena. I cannot accept that. Prachi.
Ma'am, it shows the myxoid stroma and the
There is a
metaplasia.
myxochondroid stroma. Yes, you can see that. There's a myxoid stroma. Maybe there are some little lacunae here. So there may be some chondroid
Chondroids. Yes.
differentiation. Yeah. Yes, there is a myxochondroid stroma. Excellent. All right, Prachi. Anything else?
No,
Nothing?
ma'am.
Nothing. Okay, come on, Jupiter. Huh, Jupiter? No? Bharti?
Cells with indistinct borders.
Indistinct borders to what, Bharti? You're right, but please articulate what you know well. Huh?
Group of cells with indistinct borders, ma'am. They are.
See all of these cells. Okay, I don't know if you noticed that there are some hyaline cells here. Okay, with their plasmacytoid with a very pink cytoplasm that is what we call a hyaline cell. But see the way that these cells are diffusing out into the stroma. Do you understand what I'm saying? They're diffusing out into the stroma. There is no sharp border to any of these cells. Everywhere, the cells are diffusing out into the stroma. It has a very irregular border to the cell groups. There are no nests over here, which nice sharply circumscribed borders. Okay, so that's another characteristic of myoepithelial cells. So we talked about spindle, oval. We said that there were some hyaline cells. We said that there was a myxochondrite stroma, and this peculiar diffusing of cells into the, and overall notice that they're all rather bland. Okay, I have never seen any myoepithelial tumor that is so high grade, then it looks like a sarcoma. Okay, otherwise myoepithelial tumors, whether they are tumors with myoepithelial cells, whether they are benign or they are malignant, are usually low grade in character. Okay, so you don't see a lot of mitoses and other stuff. If I had seen a whole lot of mitoses, my suspicion that these are myoepithelial cells would be low. Okay, but everything else is telling me here that this is a tumor which has got a lot of myoepithelial cells. Okay, very good. So we recognized some of the characteristics of a myoepithelial cell over here. All right. What about here now? So who didn't talk? Dhanashri, do you think that there are myoepithelial cells in this tumor? That's all that we want to do. We want to recognize different things in a tumor, and myoepithelial cells, the Cinderella cell, the myoepithelial cell is the first thing we should try to recognize once we know that this is a salivary gland tumor. Chalo. Come on, Dhanashri.
Yes, ma'am. I think these are myoepithelial cells.
You think that there are myoepithelial cells. All right. Why do you think there are myoepithelial cells?
Ma'am, I think these are clear cells.
There are clear cells. Now, I don't see too many clear cells, but maybe one or two here or there. But no, I don't see too many clear cells. If you're saying these, I don't even know whether that's a space in the... Okay, so next thought. If you said yes, then why? And if you said it about the clear cells, then I'm not impressed. Chetan, do you think that there are myoepithelial cells?
Yes, ma'am.
Why?
They have indistinct borders of the cell group in the center.
Yes. There are indistinct borders. It is all, sort of melting into the stroma. Excellent. Yes, Chetan. Then?
Also, there is the plasmacytoid appearance of some cells.
Yes, in fact, maybe you can't see it here, but maybe it is in the next thing. All of these up here in this top right-hand corner, all plasmacytoid cells. You can't see them, but we'll see it. I think it'll come up in the next.
Stroma is also well myxoid.
Sorry? There is a myxoid stroma. Yes. There is a chondromyxoid stroma. Okay, very good. Anything else, Chetan, or I'll go to Bharti?
Ma'am, there is keratinization also.
There you are. Excellent. There is keratinization that is seen, and you see these little modules with keratinization in the center. Okay, so that tells you, with all the other things that you have been noticing, This is a myoepithelial cell proliferation. But you see something else as well. Jupiter, can you take a stab at it? What else is seen here, which tells you that these are myoepithelial cells? Yeah, Jupiter? Or Meenal, or Prachi, or Manali, what's going on in the chat box?
In the chat box, plasmacytoid cells, spindle cells, chondromyxoid background, pinkish
Huh?
material deposit, squamous differentiation,
Okay.
and
All right, I'll give Jupiter a hint. What are these big cysts? We
Ma'am,
said that we had to look for something, no? We said in the my second thing,
lumina, ma'am.
they are lumina.
No.
All right. Are they true or
Yes.
false?
True.
True. Why are they true?
They're filled with secretion.
They're
Because
lined
they have
by,
secretions.
Lined by dual epithelial.
they're lined by
Absolutely.
the
There is a
myoepithelials.
luminal and an abluminal abluminal layer. And the abluminal layer, like what Chetan said, is diffusing out. See this? This is a true lumen. And you can see the abluminal layer is thick and is diffusing out into the stroma. Okay? So it has to have myoepithelial cells. Okay? So now we have made certain observations in the last slide. In this slide, here we are actually seeing not just myoepithelial cells. The last slide had absolutely not sheets, but all the areas showed myoepithelial cells. Here, now we are seeing cysts, lumina. Okay, those are not lined by myoepithelial cells. What are they lined by, Meenal? What are they lined by? Hmm? Are you there, Meenal?
Yes, ma'am.
So what is this? These cysts are lined by what?
Epithelial cells.
Yes, epithelial cells. And outside this flattened lining of epithelial cells, you can see the
Yes.
myoepithelial.
Myoepithelial cells.
Fantastic. So now we have made more observations. Yes, good. Now you can see this at higher power. Some of these things, all of these cells over here, these bland looking cells in which you can hardly see the cytoplasm. Okay? But they are laying down this myxoid stroma. You can see here keratinizing epithelium. These are all myoepithelial cells. Okay? And there are some lumina over here. See? And they're lined by luminal cells, and outside them are these. Does it make sense to all of you?
Yes,
Here
sir.
is another group of myoepithelial cells with squamous change, but on the outside there is squamous change. Here there is like a morule in which there is squamous change, and I showed you keratinization here. There is squamous and squamous, okay? So you can get myoepithelial cells that differentiate centrally into squamous or even peripherally into squamous, as you are seeing here, okay? But this myxoid stroma, in which these cells are embedded in a kind of diffusely scattered way with no clear finger, even if you take each of these, okay? Yeah, they're vaguely, but very, very irregular borders. Okay, the myoepithelial cell is an untidy cell in most circumstances. Okay, now you saw that one, that is the keratinization. It's just a high power of whatever we saw there. And you're seeing some plasmacytoid forms over here. Okay, this was also got it. I don't know if I have a high power. Yes, here we are. This is the classic plasmacytoid cells or the hyaline cells. They have a lot of pink, glassy, opaque cytoplasm. Do you agree? Or if somebody has any doubt about that, please challenge me. I find that too many people, just sit and just swallow undigestedly whatever is told you. So here is more myxoid in the stroma, and you see these lovely hyaline or plasmacytoid cells. Any problems about that, Prachi?
No,
Yes,
ma'am.
Prachi? No. So now we have seen lots of myoepithelial cells. Okay. Has this got myoepithelial cells in it, Dhanashri?
Yes, ma'am.
Yeah, well, you can suspect that it has got myoepithelial cells, right? Why?
Yes.
Because it's spindly and there are short oval cells as well. So,
Hyalinized.
yeah, there may be some hyalinization. We've not seen a lot of hyalinization. There may be some fibrostroma, but bland looking spindle or oval cells show in some places they actually have these nuclei with blunt edges, which looks like the nucleus of a smooth muscle cell, except that this is not very pink. If this were a true smooth muscle cell, it would be very pink. It's not, but it has a smooth muscle type nucleus. Very good, Dhanashri. Now, who's going to take this? Bharti, do you think there are myoepithelial cells or no myoepithelial cells? What do you think? This is how we make diagnosis, okay? I do not believe that immunohistochemistry helps in most salivary gland tumors, okay? I mean, if you're lazy, your mind is lazy, you don't want to look at morphology, then yes, throw immunohistochemistry at anything. Come on, Bharti, myoepithelial cells or no myoepithelial cells?
Adenoid arrangement.
Now, what is your checklist for myoepithelial cells, Bharti? Come on.
It should
What is the
have
checklist?
basaloid appearance.
All right.
And
So does this have a
matrix-
basaloid appearance? Do
No,
the
ma'am.
cells have a basaloid appearance?
No, ma'am.
No, ma'am. Why? What do they have? Lots of pink cytoplasm.
Mm.
Yes?
Yes,
You
ma'am.
see lots of pink cytoplasm to the cells.
Mm.
Really? All right. Does everybody agree with Bharti? Chetan, you think there's lots of pink cytoplasm to the cells or is it outside the cells?
Outside this.
It's outside,
Then,
not to the cell.
so then Bharti, you have an issue with calling this basaloid? And I don't see much pink cytoplasm to the cells. I just see these little small nuclei. Yeah. And whatever is pink is outside. There's hyaline that is
So
seen.
it can be called as basaloid.
Yes. So yes. So you've got your checklist, you know. I saw you writing basaloid.
Yeah.
So read your checklist. I'm not
Basaloid
expecting you to-
appearance.
okay, then.
Then variety of matrices should be either chondroid, myxoid,
Yeah, so
hyaline,
then
or
which matrix are you seeing here?
hyaline.
So there is a hyaline matrix. Very good. So some basaloid cells, hyaline matrix. Then what else is in your checklist?
Hyaline or plasmacytoid cells.
I don't think they're there.
Yeah, no,
No?
ma'am.
No. Then?
No spindle cells.
Very good.
And
Then?
I couldn't see any clear cells.
Very good.
And there are no cells with indistinct border or groups.
Excellent. All right. Now, what's the
Adenoid
next thing?
structures.
Adenoid structures. So are there adenoid structures? What? So what is an adenoid structure?
Tube.
So now comes the question, what is an adenoid structure? All right. Do you see spaces? Do you see lumina? I mean, to me, that's the thing that strikes me most, that I am seeing very
Adenoid.
irregular lumina. And they're all interconnected with one another. So this is adenoid? I don't know
Adenoid.
about it being adenoid. Huh? Do you think that in any circumstance you would think that this was a gland? What, Bharti? Because adenoid means gland-like. So would you start to think that this was a gland? What? Yeah, these are all glands that are being formed. Bharti shaking her head.
No, ma'am, but
Yes.
they are interconnecting, so I wouldn't.
So these are spaces, no? So
Yeah.
they are spaces. So what spaces are there? That's what my mind will be asking. I see spaces. What are these spaces? So come on, Bharti, what are these spaces? Jupiter, what are these spaces?
Basaloid matrix.
Basaloid. What do you mean by basaloid matrix? Huh? I see spaces, yes. I see some kind of faint pink material that is in these spaces. Yeah, some places it may be
Cribriform
greenish.
spaces.
Huh?
Cribriform spaces.
Cribriform. This is not cribriform. Cribriform are all uniform, well punched out areas. These are not well punched out. Okay, so when I see luminar and I see spaces, the next thing that my mind asks, are these true lumina? Or if not, they are false lumina. And what are false lumina? What is adenoid? It means that this is not a space that is bounded by epithelial cells. That's number one, okay? Number two, if we have to, they're not true lumina, then they are false, and false lumina occur in the stroma. So now, is this a stromal space or is this a true luminal space?
Stromal space, ma'am.
How do you know it's a stromal space?
Not lined.
Not lined. I would say, somebody will tell me, oh, it is lined. How are you going to tell them that it is not lined? Huh? Look carefully. What should you find in the stroma that you are seeing in several of these spaces? Anybody writing in the chat box?
And the highlight material.
Chat box, they are mentioning stromal spaces.
Stromal spaces, yes, but why? I don't just accept stuff like that without a reason.
Ma'am, highlight materials.
There are small blood vessels that you can see in this. Look at them. There are small blood vessels. Apart from the fact that you see some matrix, you see the matrix here, you see the matrix there, you see a matrix there, there's matrix, and you are seeing small little blood vessels and stromal cells that are sitting inside this. All right, so it's a stromal space. Now, how do you get stromal spaces? Huh? How does a stromal space form, Meenal? Come on, Meenal. How does a stromal space form?
Due to the
How does it? Yes. How does a stromal space form? Nobody's got an answer. Is anybody writing in the chat box?
Extracellular matrix, they are mentioning.
Extracellular matrix. So what is producing this extracellular matrix? Huh? And don't tell me that the lumen doesn't have an extracellular, it doesn't have a matrix, but extracellular material is also present in the lumen. No, that is secretion. So the stroma also has an extracellular secretion. Only that secretion we call a matrix. So what is producing this extracellular stromal secretion? What produces it? If it is in bone, it is the osteocyte. If it is in cartilage, there is a matrix, no? So it is the cartilaginous cell. So now in such a case, what do you think is producing? You think it's the blood vessels that are producing it? You think some fibroblasts are producing it? What do you think is producing it over there? Here, Chetan?
Myoepithelial cells.
Myoepithelial cells. Because the myoepithelial cells are abluminal, they are in contact with the stroma. What is outside the myoepithelial cells, my friends? What is outside the myoepithelial cells?
Basement membrane.
Basement membrane.
If they make the basement membrane, otherwise, What do you think is producing myxochondroid? It's the myoepithelial cells, no?
Yes, ma'am.
Oh, yes. So they're either producing basement membrane, or they're producing myxoid, or they're producing chondroid, or they're producing hyalin, or whatever else. It is the myoepithelial cells that produce it. So what do I see here? With my eyes shut, I can tell you that this is a stromal space. Okay, and that stromal space is filled with something which has been produced by something that is towards the stroma. It cannot be produced by luminal cells, okay? And why do I know it's a stromal space? Yes, Prachi? Why
As
do I
ma'am, we
know
can
it's a...
see the blood
You can
vessels.
see, you can see fibroblasts, you can see blood vessels, they are all there. And so if it is a stromal space and something is producing material that's going to lie in that stromal space, then the only thing in a tumor that can do this is a myoepithelial cell, because it is adjacent to a stromal space. Yes or no? Anybody have
Yes, ma'am.
any difficulty about this? There's hyalin here, there is the stromal space, which is filled with this sort of very wispy...
And where are the blood vessels?
Sorry?
Blood
Where are the
vessels.
blood vessels? Here they are, no? See where can you see my cursor? Can everybody see my cursor?
Yes, cursor.
So, right, you seen where my cursor has gone now? That's a blood vessel. Okay, there are lots of little blood vessels inside these spaces. And if you're careful, you will look for them. So this is a stromal space. Okay, you can't have secretions in a lumen when you have small little stromal fibroblasts and other things that are lying in a space like this, no? A lumen is usually empty. You don't get cells sitting inside a lumen, do you? Unless it is debris, like comedonecrosis or something of that sort. So have you got the point? Okay, so this is very likely to be a myoepithelial proliferation or cells. We can prove it later, but if somebody asks you, do you think that this tumor has myoepithelial cells, what will your answer be?
Yes, it is.
Yes.
Yes. Okay. More likely than not, this has myoepithelial cells. Okay. What do you think about this? Chetan, you can see that there is a squamous
Yes.
epithelium on top, and this tumor is lying just below the squamous epithelium. So it cannot be the parotid, it cannot be the submandibular gland. So what is this? Where do you think this biopsy is from, Chetan? Parotid?
No, ma'am.
Yeah, Chetan? Parotid?
No, ma'am.
No. So from where?
Can be submandibular.
Submandibular.
Or ma'am, it
Submandibular.
can be some minor salivary gland.
Then say that, no? Minor salivary gland.
Minor
That's
salivary.
the first thing that comes into your head. Okay,
Yeah.
now tell me. What do you think? Does it have myoepithelial cells or not?
I can see some clear cells.
Ah, very good. It is full of clear cells. Yes.
ma'am. Clear cells are there.
Right? Excellent.
And also, ma'am, there is
What?
the stroma is
Stroma is?
somewhat myxoid.
Now, Chetan, you're just making it up. All right? There is no myxoid over here. What is the stroma like, Dhanashri?
Ma'am, I don't see any stroma. I see
You
mostly.
don't? My God, it's all floating in the air.
I see
Jupiter?
clear cells.
I can see clear cells, but they're all floating in the air. Jupiter? Are you there? What's the
Yes,
stroma?
ma'am. I'm highly.
Absolutely. This is all hyaline, and you can see that. It's there. It's there around these groups of cells. So what are you seeing over here? Are you seeing some diffusion, or what? Jupiter, what are you seeing? Chetan said that there are clear cells. Dhanashree said there is no stroma, which is not true. There is stroma, and the stroma is hyaline, which you very rightly pointed out. It's all hyaline stroma. Okay? So it's possible that these are myoepithelial cells, but we have to go a little deeper. And what is that deeper? I'm asking you, what kind of pattern are these cells in? What are they making? What kind of growth?
Nest.
They are nested.
Ma'am, nest.
Nests. Yes, they are nests. Now, what did we say about myoepithelial cells? That they very seldom form nests. What did we say about myoepithelial cells, Chetan?
Myoepithelial membrane that we see.
Sorry?
Nest.
They form nests. Huh?
Seldom.
What did I say about how myoepithelial cells organize themselves? That's the one thing they do not do, no? They just diffuse out into the
They are
stroma, no?
indistinct. Yeah,
So
they
are
have
you
indistinct.
telling me that this is diffusing out? It's
No,
forming
ma'am, it's not
nests.
diffused.
Aha! Oh, it is diffuse in the way that it is growing, but they are forming nests. You can see the nests. And each of the nests is surrounded by a hyaline. Yes or no? A hyaline stroma. So, Dhanashree, do you see the stroma or you don't?
Yes, ma'am.
So you should not have said that there is no stroma because it's not floating. There is something between groups of cells over here and there are nests. Okay, so yes, Dhanashree, there is this. So is there or do you feel that there are myoepithelial cells? So what's the answer, Dhanashree?
Yes.
The answer is yes. Then
But
you
they're
haven't been paying attention to anything we've been saying. Meenal, what's the answer?
Yes, ma'am, myoepithelial cells are there.
Myoepithelial cells, Meenal. Okay, Prachi?
Yes, ma'am. Myoepithelial cells are
Yes,
there.
okay. What is going on in the chat box? Jupiter?
They're forming nests, so
So yes, Jupiter,
cannot be-
so therefore,
it cannot
not
be
myoepithelial.
myoepithelial cells.
it is less likely that these are
It to be
myoepithelial cells. They are clear
Yes.
cells, yes. They're looking bland. You don't see any cytoplasm. There is the nuclei are vesicular, okay, and they are elongated and a little irregular and some oval, okay. But we said that myoepithelial cells tend to diffuse out, and this is not diffusing out, it's forming nests. So what's wrong with you, Dhanashree and Meenal and Prachi, who said, yes, these are myoepithelial cells? You can't say yes. The answer is perhaps or perhaps not. There are some clear cells over here. Yes, there is a hyaline stroma, but all of the characteristics are not fitting, right? So
Yes.
may or may not be. Okay, so this is how we sit and dissect out whether or not there are myoepithelial cells. Okay, now who's the next person over there? Bharti.
Yes, ma'am.
Are there myoepithelial cells or not? Come on, come on. We just have one or two more.
Stroma is hyalinized, but
Stroma
cells
is
are not.
hyalinized.
Ma'am, cells.
Stroma is hyalinized.
I don't think so, ma'am. They are myoepithelial cells.
You don't think so. So if you say no, then you have to tell me why.
First, the cells are not basaloid in appearance, ma'am, because they.
So you think that these cells were basaloid? Bharti?
They are not. They are not basaloid.
They thought you call these
And they are not spindle or
not
clear or
basaloid.
plasmacytoid.
Huh? So you're
They're not
just going, you
spindle.
are just looking at your checklist and you're going one by one.
And they are not bland also, ma'am.
They are not bland. Excellent. These are not bland. Very good. Yes. So what are the cells like, Bharti?
Highly pleomorphic, ma'am.
Okay. They are pleomorphic. There are big cells, small cells. What are the nuclei like, Bharti?
Vesicular with prominent nucleoli.
Ah, very good. And what are the cell cytoplasm like?
A scant cytoplasm.
Scanty.
But,
Scanty
eosinophilic.
cytoplasm. I'm going to have a heart attack here and
Eosinophilic. Sorry, ma'am. Eosinophilic cytoplasm.
okay, eosinophilic. That's all you saw. Eosinophilic cytoplasm.
Moderate eosinophilic cytoplasm.
Oh my God. Moderate eosinophilic cytoplasm.
And
Everybody agrees with Bharti? Dhanashri, you agree with Bharti? That is moderate eosinophilic cytoplasm?
No, there's abundant
Oh, I
eosinophils.
should think it is abundant. Look at this cytoplasm. It's abundant. Look at this cytoplasm, which is abundant. Okay. A lot of these cells have got abundant cytoplasm. And what kind of abundant cytoplasm, Dhanashri?
Pale to eosinophilic to at places there are pale
Hey,
cytoplasm.
you don't see that? What are these big vacuoles that are seen in the... Look at this nucleus. Look at these big vacuoles. You don't see this vacuole? Huge vacuole in the cytoplasm. I don't know. Have all of you just lost your... Or maybe you've lost your concentration. I'm sorry. But I can see these huge cells with nucleoli and vacuoles, large vacuoles in the cytoplasm. Okay, so this cannot be myoepithelial cells. Okay, and we said that myoepithelial cells, and Bharti said it right, there's too much pleomorphism here. Myoepithelial cells never show you this amount of pleomorphism, vesicular nuclei, huge nucleoli, etc. So this tumor does not have myoepithelial cells. Now, what it is a different thing altogether. We're only trying to recognize whether or not there are myoepithelial cells. All right. Now, Meenal,
Yes, ma'am.
myoepithelial cells?
Yes, ma'am.
There's one on the left and one on the right.
On the left, there is more of this chondromyxoid-like matrix,
Excellent, very good.
and there are few spindle-like cells,
All
spindle
right.
shaped.
And you can see the diffusion into the stroma. Yes, so there are myoepithelial cells. Okay,
Epithelial cells are there.
very good. Anything else that you notice?
Ma'am, arrangement few maybe are in the trabecular pattern.
Do you see anything besides myoepithelial cells? Yes, these are all myoepithelial cells. Then what else do you see here?
Luminal.
Ah, there are lumina. And the lumina are what? Are you think all that is here outside the lumen is myoepithelial cells? Oh, there are myoepithelial cells here. There's mitochondria. But what is this? There are lumina and they are not lined by myoepithelial cells. Ah, so these lumina have got very, very atypical luminal cells. Okay, so something else is going on here. You have luminal, you have abluminal cells, lots of myoepithelial cells, but now these cells are becoming abnormal. Okay, the luminal cells are becoming abnormal, and perhaps that we are going to get a change in, if we only had this, we would probably say myoepithelial like pleomorphic adenoma, that some change may be happening in that. Okay, now what about Chetan? Tell me what you're seeing on the right hand side.
Lots of stroma, hyalinized stroma.
Hyalinized stroma, excellent.
And lumens are seen.
Very good. And so are they
cellularity
cells or not?
Cellularity is low, basically.
Cellularity is low. That's neither here nor there. Tell me, are there myoepithelial cells? That's all I want to know. Myoepithelial cells or no myoepithelial cells?
I can't make out any myoepithelial cells.
Huh? Chetan? Okay. Jupiter? Chetan is stumped. He found.
Ma'am, no myoepithelial cells.
Sorry, what did you say, Jupiter?
Ma'am, there are no myoepithelial cells.
Jupiter says no myoepithelial cells. Prachi?
Ma'am, I'm still having the previous slide. I don't know why.
Sorry. Oh, it's stuck. Sorry.
Yes, ma'am.
I don't know. I'll go back.
Can I rejoin?
No, 1 minute.
the-
Don't worry. Let me see. You got now you've got another slide or you haven't?
No, ma'am, I'm still having a previous one slide.
Then you may have to rejoin. Okay. So let me ask Dhanashri. Dhanashri,
No, ma'am, I don't see any myoepithelial
you
cells.
don't see any. Meenal,
Ma'am, no, ma'am.
Bharti? Bharti, you there?
Yes, ma'am.
So,
There are lumina, ma'am. Stroma is having lumina and
stroma cannot have lumina.
lumina. Yeah, the
No,
false
I'm sorry,
lumina. is there.
stroma does not have lumina.
False lumina.
False lumina. Acha.
Mm.
Okay. Do you think there are false lumina, Jupiter?
No, ma'am.
No.
No.
These are true lumina. Okay. But they are not lined on the outside by myoepithelial cells, and yet there is intense hyalinization. And do you think these lumina, the cells are very nice looking? No, no.
No.
There is a lot of variation and also, apoptotic cells, dark cells, big cells, etc. And what did I tell you? That you should look for hyalinization, right? Why? Not only for myoepithelial cells and basal cells.
Long-term tumor.
A tumor that has been present for a long time and is changing its character, and this is now become a duct carcinoma. Okay, dense hyalinization in a tumor which has got only luminal type cells, no myoepithelial cells, true lumina over here. So this is a duct carcinoma. You just see this and you know it. On the left hand side, there is a pleomorphic adenoma and it is slowly changing its character. Therefore, there will be myoepithelial cells because it's a pleomorphic adenoma. All pleomorphic adenomas have myoepithelial cells, but now something is happening to the luminal cells here. And in this case, on the right hand side, it has already happened, and this tumor is a high-grade duct carcinoma. All right. Now, there are no prizes for telling me what this is. Are there myoepithelial cells over here? Meenal?
Yes.
Oh, Chetan says yes. Okay, Meenal, are there myoepithelial cells? Meenal.
It's just changed, ma'am. I'm just checking.
Sorry,
because-
I'm so sorry. It was you who are. Dhanashri, are there myoepithelial cells?
No, ma'am.
No, ma'am. Will you tell Chetan why you're saying no?
These are all oncocytic cells.
Everything is oncocytic. Chetan will tell you that there are luminal and abluminal cells. So what are you going to tell Chetan? It's double layered, no?
Yes, ma'am.
So why are you not saying that the abluminal cells are myoepithelial cells? That's the abluminal. Yeah?
They are.
There are papillae with an outer layer and an inner layer. It's a double luminal cell. So, Bharti, are there myoepithelial cells or no myoepithelial cells?
They are basal cells, ma'am. They are
They
not
are basal cells. Excellent, Bharti. So, will you tell Chetan, why are you calling these basal cells? Why? He said myoepithelial cells because he saw abluminal cells. And in Chetan's mind, every abluminal cell is a myoepithelial cell. Isn't that right, Chetan?
I thought so that it was abluminal myoepithelial.
So
It should be spindle shaped, not to call it as
but it doesn't
myoepithelial.
have to be spindle shaped. It can be any shape. We've seen myoepithelial
But it is
cells
not
that
diffuse.
But and it is very diffuse, ma'am.
That's not the reason. The reason is that you have got luminal cells that are oncocytic, and therefore this tumor has probably come from what?
Striated.
The striated duct. And the striated duct never has myoepithelial cells. It only has basal cells. Have you got the point? Why did I spend so much time on intercalated and acinic and striated? This is a tumor of the striated duct, please. And therefore it's oncocytic. Wherever an oncocyte arises from, it will be from the striated duct. And if there happens to be a double lining, inner and outer, the outer or inner, whichever way you want to call it, is going to be a basal layer. Have you understood this? Yeah.
Yes.
So it's not about making a diagnosis. Anybody can make a diagnosis of a Warthin tumor. Okay. It is a Warthin tumor, yes, but it has a double layer of cells, but that double layer, one is luminal, the other is basal. Have you understood this or not, Chetan? What
Yes,
did you
ma'am.
understand, Chetan, now? Tell me.
Ma'am, this is the double layer, which I suspected. The abluminal layer, I thought it was myoepithelial, but it is basal
Why?
cells.
Because
It is from the striated duct.
no, that's not the reason. Because all
It is
abluminal cells
oxyphilic
are
cells.
not necessarily myoepithelial cells. There are two kinds of abluminal cells. One lot is myoepithelial, the other lot is basal. Recognize it by knowing more or less where this tumor is actually coming from. All right. Okay, so we're not going to do ancillary techniques now. We will do it the next time when I show you the actual salivary gland tumors. Okay, I have sent a set of tumors to Dr. Gujral. He'll probably share it on Telegram, so you can look at those tumors and some of the the techniques, or rather the points that we have discussed today, we will apply them in those salivary gland tumors, and let us see how we arrive at the diagnosis. Okay, so I think we can stop now. I will stop my slide sharing, because I don't want people to believe that you only make diagnosis by doing immunohistochemistry. We don't. All right, very good. Any questions that you have for me? Manali, is there anything in the chat box? Is there anything? Let me see. I can also.
There are 3 questions.
Excellent. Tell me, Manali, what's the question?
The first is, initially you showed the study, which was audit of salivary gland tumors.
Yes.
So Akshay has asked, is it still relevant as the study is 20 years old?
Of course it is relevant.
Then second question was, how sclerosing polycystic adenosis in the salivary glands is different from that of breast?
It is more or less the same. That's why it was recognized as being. What do you mean by different? It is the same disease, except that it is occurring one in the salivary gland, the other one in the breast. Okay?
Yes, and
everything is relevant. It's always old. It is always old wine in new bottles. Okay? So never think that that everything changes unless there happens to be a completely new set of etiology. And what I mean is, suppose there was, some new disease has turned up, because it's like COVID. We didn't have COVID before. Now we have COVID. Okay. So that's because there has been a new virus that has jumped from here to there. The same thing can happen. You get new tumors depending upon, not because we give them different names, but because there has been a change in our lifestyle, maybe the air that we breathe or whatever else, and then different tumors turn up. Okay, everything is relevant. Very good. Now, anything else?
third question was, are there myoepithelial cells in polymorphous low-grade adenoma? adenocarcinoma.
Sorry, what was the question? I didn't pay attention.
Presence of myoepithelial cells in polymorphous low-grade adenocarcinoma.
There are myoepithelial cells there, and you will see some cases of polymorphous low-grade adenocarcinoma. It will be in mine, and they are there. It's an adenocarcinoma, but it has myoepithelial cells. As acinic cell carcinoma, adenocytic carcinoma is a carcinoma, but it has myoepithelial cells. So why should we worry about whether myoepithelial cells occur in a carcinoma or not? Of course they do. I don't understand the actual relevance of the question. But there is somebody here, Hina, who says, how to know in slide where squamous epithelium was seen? And how is it only submandibular? It was not the submandibular gland. That was Chetan who made it up and said that it was the submandibular gland. It was not. It was a minor salivary gland. So if you see squamous epithelium on top and it's benign, and there is a tumor arising in that mucosa, then it is a minor salivary gland, no? I hope, Hina, you've got that right. Okay? Now, Babita is asked, basal cell adenoma does not occur in minor salivary glands. Your comments? Yes, basal cell adenoma is very, very uncommon because you don't have striated ducts in minor salivary glands. No, you get them only in the major salivary glands. And basal cells are essentially not seen in, are only seen in striated ducts and excretory ducts. So you're very unlikely to see a basal cell adenoma in a minor salivary gland. Okay, you see it in the parotid, you see it occasionally in the submandibular gland. Then, biology is such that it's a very good reason for most things to happen. So thank you, Babita, for asking that question. Okay. Very good. Now, any other questions? No. Did I answer all of them, or anybody wants to add a few more? I'd be happy to.
Ma'am, I have one question.
Yes, please, Chetan. Very happy.
Ma'am, yes, as we have discussed, as myoepithelial cells have indistinct borders. So they are diffusely.
They don't have indistinct borders.
No, they are present diffusely.
Out into the stroma. So the cell groups have indistinct borders.
Yeah. So, ma'am, does they have any group form, or like in one of your slide you said myoepithelial mantle has sheets, trabecular, and cribriform. So what does that mean?
Have got what?
In one of the slide, it was there myoepithelial mantle was there in sheets, trabecular, and cribriform.
Yes. So you saw, no, the trabeculae of those myoepithelial cells, the basaloid one in which there was those spaces in the stroma. I can't show it again because I'll have to share again. I don't mind sharing it again. But they were forming little trabeculae. That's okay. But the way you recognize myoepithelial cells, or you tend to think that there are myoepithelial cells, if you have this diffusing out into the stroma. If there is no diffusing out in the stroma, it may still be myoepithelial cells, but not showing you that particular characteristic. So if you see nests, you are less likely to believe that they are myoepithelial cells. So there are characteristics, and you have to weigh them against one another. And in the end, if you don't know, then you resort to something else like immunohistochemistry or other. But myoepithelial cells don't obey every rule of the myoepithelial cell. Okay? Anything else?
Ma'am, there is one more question. What is the difference between myxoid and hyalinized stroma?
Myxoid is blue, hyaline is pink. I don't know who's asked that question, but this is one of the first things we learn in histopathology as to what different stromal types there are. And hyaline is an intensely collagenized tissue, which I think that there is a silly description, and that is glassy. I cannot see glassy on an H&E. Okay, but if you have hyalinized tissue, like a very hyalinized scar, right, and you look at it on gross, you see tendon. All right, have you ever seen tendon? Tendon is intensely hyalinized, And have you noticed that how the tendon looks on gross? Who has seen tendon on gross? Anybody seen tendon on gross? You seen it, Manali?
Yes.
You
Yes,
have?
ma'am.
Where?
Yes, ma'am.
Yes, ma'am.
Where have you seen tendon? Anytime recently? You saw it
Amputation
in anatomy, huh?
in the
Yes, ma'am.
amputation.
In amputation.
Amputation specific. Excellent. So how does it look?
It is like white, tough
Is it
string.
just white?
Tough
It's not just
Glistening.
white.
It's
Yes?
glistening and see-through.
glistening white.
Glistens. Okay, so it has that glistening, glassy look. And what is giving that glassy look? You don't put water on it so that it glistens, no? So that is what this glassy, glistening appearance is about. And that's exactly the kind of dense collagenized tissue, because that's what tendon is, that you see in hyalinization. And because of that, that term has come as hyaline glassy. Okay, you can't see glassy when you a texture when you're looking at it under the microscope. Okay, we can't see rough. Can you see rough? Can you see any texture under the microscope? You know what is texture? Texture is a feel. Okay, you can't under a microscope, but we are trained not by by somebody sitting there and training us, but we see something and we imagine how it would feel. Okay, so that is what it is. Now I can ask you another question. Okay, whoever asked the, I don't know if somebody asked about glassy or I came up with that glassy or hyaline. I think the question was about mixoid. Mixoid is loose and blue, and glassy is dense and as not glassy. Hyaline is dense and pink. Okay, so you cannot mix up the two. Fibroblasts, myofibroblasts, myoepithelial cells, all of them can produce mixoid and they can produce a glassy collagen because they're all stages in the formation of very dense collagen. So that's the story about glassy. But I want to ask you, since I've got 6 captive people over here, Chetan, we talk about caseous being cheesy, you know. You've
Yes,
seen
ma'am.
caseous necrosis, Chetan?
Yes, ma'am. Yes, ma'am.
Why is it called caseous? Well, how is it different from other necrosis that you see under the microscope? We say no caseous necrosis. Yes or no?
Yes,
Yeah.
ma'am.
Now
We
all
see.
of you think, Bharti, why do we call it caseous? Prachi, why do we call it caseous? Does it look any different from a necrosis in any other part of the body? Say a tumor necrosis. Why don't we call that caseous? Nina?
Grossly, it looks like
It
cheesy.
grossly produces
Ah,
cheesy
it is
material.
gross. It is a gross picture. So liquefactive necrosis is a gross appearance. Coagulative necrosis is also a gross appearance. It's like what happens when something clots. No, that is coagulation. Not red clot, but a white clot. So that is what is coagulative necrosis. And caseous necrosis is cheesy. You know, like paneer, that is what caseous necrosis looks like under on gross examination. But all students tell me that this is a histological appearance. I'm sorry, it is not. Okay? All these 3 kinds of necrosis are gross appearances, and we just apply them to histological pictures, although strictly speaking, you cannot. Understood? So students tell me, oh, you can see the outlines of the cells in coagulative necrosis. You may or may not see the outlines of the cells in coagulative necrosis. It's the gross appearance that is important. Okay? Now, Hina, you've got your answer. Anybody else? Myxoid, hyalinized stroma, then
It's done, ma'am. No questions.
All right, very good. Babita, you want to see clear cell carcinoma of salivary glands. Don't worry, you will see it. Okay, but it should better be recognized as clear cell. Okay, I think Mingu Chi, yes, cheese like grossly. Excellent, Mingu. Mingu, where are you from? Right where you are from, Mingu, so that I know. Okay, that's very good. Please, there we mix up lots of things that were described grossly from there. Okay. Thank you, Sandeep. You have been very patient.